Okay, so the previous slides went ahead and walked you through. hmm. So now that you've completed the testing protocols for the SCAT-6, it's time to make the decision on what happens. So in many cases, this would be when that athlete receives a diagnosis, a clinical diagnosis of a concussion that can be further clarified or confirmed with our team physician, but we have to determine some of the next steps. So after they get cleared by the physician and they are, the most important part, symptom and medication free. So we know there's a variety of symptoms with concussions of varying levels of severity, but if they are still taking medication to mask those symptoms, they're not truly symptom free. They're just not presenting symptoms because the meds are doing their job. So things like Tylenol for headaches, if you're still popping Tylenol for the headaches that you have because of the concussion, you are not symptom free. So once you are symptom and medication free, we can start this return to play protocol. So this is included in the next slide and then also in your SCAT packet as well. In addition to the return to play, because we're usually working with athletes, we also have to consider the non-athletes or just the fact that many of them are still students. So if you are missing class because of the concussion signs and symptoms, we got to do return to learn protocols first. You're not going to, skip class all week long and then be ready for Friday Night Lights. That's not how it works. You've got to return to all your classes first. So when we're thinking about a lot of these symptoms, we know headache, sensitivity to light and sound, difficulty concentrating, remembering, things like that are definitely one of those symptoms or some of the symptoms that might be more prominent that can really interfere with a lot of classroom performance. So after they have successfully returned to their class and maybe caught up on any schoolwork that they have missed, then again, we'll start that gradual return to play protocol. So moving on to the next slide, if we look at how this is actually staggered, this is just the text version of the same next slide. We're doing no activity first. So again, cognitive, your brain rest is going to be one of those first things along with physical rest. So don't be doing a whole lot of physical activity. We're not worried about maintaining cardio. We're not doing any kind of team lift. We're not doing any conditioning at all. Let your mind rest, let your body rest, right? So concussion signs and symptoms are either physical or cognitive in nature. They affect the physical aspect of you or just the way that your brain can process information. So to be able to adequately rest them both, again, we're also going to make sure that we're just focusing on recovery at that point. So it's not a situation where they're deconditioning cardio wise because they're taking several weeks off. Again, this is usually a relatively short thing. Now, with most injuries, it's easy to give it a timeline, but with concussions, it's very complicated just because we know that no concussion is going to be the same, and the more concussions or different head traumas that someone has experienced, usually the longer their return to protocol or return to activity last. So for the first time, it might only be a couple days. The next one might take a couple weeks. So as far as when they start with that light aerobic activity or the actual first step of that protocol, it might be a while. So giving it a timeline is not super important. It's not like, this is exactly how it's structured day 1, day 2, day 3. We need to wait at least 24 hours between all of these steps. So if no activity, they're completely fine. We've returned them to school, work, things like that. And then we're looking at returning to activity. If their signs and symptoms come back after some light aerobic exercise, so stick them on the treadmill, just kind of walking, 70% max, not super difficult. The goal here is just increasing heart rate, right? We don't need to run, a 5-minute mile. That's not really the goal here. Just get the blood pumping, get moving around a little bit, and see if any of those symptoms return. So if the symptoms do return after activity and monitoring them for at least 20 minutes after, doing all of these functional exercises, then we basically just kind of stay where we are in that protocol. Some places will do it much more conservatively and make them restart that whole protocol. So going back to rest and then try again. And then if they have symptoms again, going back to rest and then try again. Some places will allow you to just kind of pause where you are and then continue to make progress. Some of it's also going to be on the severity of the symptoms. So if it is just a splitting headache that returns, we're definitely shutting them down right away. So if they successfully complete their light aerobic exercise, then we'll move on to sport-specific exercise. So here we're doing, skating drills, running drills, no head impact. So really not doing a whole lot of even team-based stuff. This is going to be maybe some drills in like a gym setting. There's no chance where they could fall and hurt themselves. There's no chance that someone's going to tackle them. They're not taking headers, anything like that. Just kind of move it around a little bit. So depending on if it's a contact or a non-contact sport, you might have to get kind of creative in these next steps. So things like cross country, we're never expecting to get hit in the first place. So when we're thinking non-contact and then full contact, how does that change throughout the rest of that protocol? So when we're thinking adding movement, we're also thinking about changing elevation a little bit. If you were running in Jones Park, right behind like Four Seasons Apartments and off Prairie, there are some higher points right around the various ponds. There's some lower dips. So you're running hills, you're having some movement changes in even your posture. If you're more of a forward leading posture, going around turns, different things like that. Just adding a little bit more movement. It's the up and down and side to side, some cutting drills, again, moving the body around, but still no impact. That next stage would be our non-contact training drills, especially if it's a contact sport. So after we've just done some really basic drills, now this could be a time where we can actually get them back with the team a little bit. Again, doing non-contact stuff though. So for football, this would be red jersey, do not hit them. They can do non-contact drills. They could do, again, some more complex stuff. This is when maybe a coach would want to get involved in looking at what looks good as far as some sport-specific function. If you're running plays, of course, your athletic trainer is probably not going to know what all those different plays are. So this could be another time where the coach could have an active role in their recovery by making sure that cognitively they are aware of those drills and they're executing them properly. When it comes to that next stage with our full contact practice, again, this is going to be pads, the ability to get hit, again, functional coordination, making sure that they're able to follow directions clearly, that they're integrating back into the team. If, and only kind of if, they have been out for several weeks and they have deconditioned, we of course want to make sure that they have achieved the full cardio, full balance, agility, that kind of stuff. But usually, again, this is very short term. We're not really worried about maintaining cardio. It's just getting them through everything like what would be normal. When we also think about different lifting and things like that in the weight room, we're not really doing that until those later stages anyway. So resistance training is something that will be one of the later things to come into play. And then if they've successfully completed, again, full practice, full contact with no return of signs or symptoms, the kind of order of this last stuff could be a little tricky depending on if you have a team physician and what your local policies and procedures are on how this works. But they'll get the final clearance from the physician to be released or medically cleared from their concussion to be able to return to play here. Now, if there's been some like spinal fractures or disc herniations or more physical neck trauma along with that, they also have to be cleared by any type of neck specialist or neurological specialist that they may have seen for that. So our team physician will have the final say because it's one person that's in charge of everybody. But if they have been referred to a specialist, they also need to be cleared of those injuries before they are considered full return to play with no restrictions. So at this point, again, they have fully integrated back into work, sport, things like that. As far as further prevention, we do need to stress that they are honest with their signs and symptoms. So if they are feeling nauseous and dizzy and kind of fatigued that they just can't rest away and they're lying about that. So if they say, I've got no signs and symptoms and we're continuing to move through this stepwise protocol, and they actually do still have symptoms, there's another condition that can develop called second impact syndrome. So we need to, again, stress the importance of their honesty with that. A lot of it also comes from knowing your athletes, right? So we can see some short-term personality changes with any type of head and brain trauma. So it could be the nicest person you've ever met and they are just a complete jerk to you. They're really short to lose their temper. They're really frustrated. They're really angry. They're throwing things, kicking things. That's not normal, right? So if you have a good working relationship with your athletes, you'll know, hey, maybe this guy's not quite acting right. This is also a situation where we would rely on coaches, teammates, position groups, things like that. Just, hey, let us know if they're not acting right. especially because in the collegiate setting, a lot of your student athletes live together. We're going to educate the roommate on things to be aware of. There's a lot of bad recommendations or just untruths out there about how to manage head injuries. Some people think you need to wake these people up every hour on the hour overnight just to make sure that they're still alive. That's not really something that is necessary. They will be very tired, usually after sustaining a head trauma, and it is okay to let them sleep. I would say, maybe check on them a couple times throughout the night, but there's no need to wake them up every hour. That's not necessary. I think some of that stems from some conditions that we'll talk about at the end of this slideshow with subdural, epidural bleeds, but the onset of that is also going to be a little bit different than your standard concussion. So here at ESU, what do? It's an NCAA requirement that we have a concussion management plan on file. So the NCAA Sports Medicine Handbook lists some very specific legal, ethical, physical guidelines on how this is implemented, who's involved in that process, when different things happen, and things like that. We also need to make sure that our athletes are aware of what a concussion actually is. If they're thinking that you have to lose consciousness to have a concussion, that's also not true. If they think that seeing stars after a hit is normal, again, that is not normal. That is a sign of brain trauma. So we do need to make sure that they are aware of what's normal, what's abnormal, who to report their signs and symptoms to, and what that process looks like. Especially some old school coaches might give them some crap about you're not tough enough, or that's just kind of how it is, and you guys are getting soft, right? That's not something that should be tolerated in the athletics realm. We expect a lot of our student athletes, but we also expect a lot of our coaches in making sure that the players are healthy and practicing to the best of their abilities. So to educate our athletes, we need to make sure that we have a good and accurate medical history on them. So when was the last time you had a concussion? What were some of those signs and symptoms? How long did it take to return to activity afterwards? Because we do know the more that you've had, the longer it might take to return, as the brain is healing. With some people, they can have maybe just one head injury and that's kind of it for them. They might be unable to return to athletics. So those are some difficult conversations that have to happen sometimes. But again, it's all for the health and safety of everyone involved. We'll also educate them on some of the legal stuff, our assumption of risks. So this is something that we've talked about in the legal chapter, with making sure that they are aware of the likelihood of injury and how to prevent that. Right, we know that no helmet can prevent against concussion. That's not even what they're for. They're to prevent scald fractures of just the bone itself, right? You can put whatever you want on the outside of it, of the skull, but that's not going to change what's happening on the inside of it. So there's an analogy sometimes about thinking about the skull and the brain as an egg, right? You can put styrofoam packing peanuts around it. You can put a parachute on it. You can put it in a cardboard box. And if you drop it off a building, right, the outside might be unaffected, but we don't know what's going on inside that egg, which is your brain. So again, you're not going to be able to see the brain trauma. This can be something that's psychologically very frustrating for a lot of athletes, because if you have a broken arm, you're going to be in a cast. If you dislocated your shoulder, you might be in a sling. If you sprained your ankle, you might be in a boot, but no one can physically see head trauma. So you might be out and everyone's kind of asking you, hey, what's going on? Why are you not playing yet? Well, I've got a concussion. Well, you look fine, you seem fine, you're acting fine. Why are you still out? Again, part of that is just the honesty and preventing these situations from getting completely out of control. This can turn into life-threatening conditions if we're not managing these head injuries properly. So educating them on the risks of especially contact sports, how to tackle properly, not using your head as a weapon, different things like that. We're also doing baseline testing. So when we think about when we're getting a baseline and what that means, usually as part of preseason physicals, it's a good time to do this stuff, or right around there, just because they're already, compiling a ton of information. You're already signing your assumption of risks and waivers and doing all your equipment fitting and different things like that. But we're really just trying to find a starting point on how they're functioning now. When you're looking at what those signs and symptoms of a concussion are, sometimes it's argued that, preseason physical is not a great time to ask some of these questions. to establish a baseline. If you think about, especially a transfer student, not really familiar with your local campus, so they just arrived here from, let's say, Hutch, and they're living in the dorms. So you're going to be bombarded with information. Here's your class schedule. We need to make sure that you're sitting in the front row, and this is what you're wearing every day, and this is how you use Canvas, and then make sure you download this app, and here's where our team meeting rooms are, and here's your advisor. You've got to park here. You've got to go to police and safety and get your permit. You've got to do this and X, Y, and Z and all the other stuff, and then be back later for training tables. I mean, it's information overload. Of course, they're going to have difficulty remembering. That's a lot of information that's completely fresh. Also, not quite what they're assessing when they say if you have difficulty remembering, right? It's not, an information overload situation. It's, are you having like some short-term amnesia, cannot remember something that I just told you like 5 seconds ago? So again, make sure they're in a comfortable environment and they understand why you're asking these questions. But a lot of the symptoms could also be good screening questions for different learning disabilities. Especially in a collegiate setting, someone might not have the same academic accommodations that they have previously had in high school, especially if they kind of coasted. They never really had to study. They could maintain good grades because they took relatively easy classes, right? So now as these major classes become a little bit more complicated, they might have to be referred to different supplementary classes, right? They might have to go to the writing center. They might have to go to tutoring. They might, different things like that. So especially if someone does say that they've got difficulty concentrating in class, that they have difficulty remembering, they've got difficulty sleeping, they sometimes just see words scrambled on a piece of paper instead of being able to read them properly. Maybe they have dyslexia, maybe they have dyscalculia and the numbers are moving around on them, right? Not necessarily a sign of a concussion, but just different learning strategies where you can receive academic accommodations through what was formerly called disability services, but student accessibility and support services on campus. So it could be, again, a good screening tool for that. You also have to be aware of sometimes how even seasonal allergies present as symptoms. So if you have pressure in your head and especially exacerbated or made worse by positional changes. If you roll on this side and, then your sinus hurts on here, and then you roll around in bed and now this side of your head hurts, and then this side of your head hurts, and things like that. That's not quite the same head pain that they're describing with a head injury. So just make sure that what they're answering questions to makes sense. You've got a sinus headache, not the same headache that we're talking about, brain trauma headache. It's completely different. So when we're establishing this baseline test, depending on your institutional policies and procedures, it can be really frustrating sometimes in how we're screening athletes and where that information goes and how it stays on file. So one of the tests that we'll talk about next is called the impact test, immediate post something concussion test, post activity, anyway, the impact test. It's a computer-based neurocognitive test that will measure processing speed and ability to follow directions, pattern recognition, different things like that. It has some technology embedded within it that if you intentionally sandbag it, you say, if this is my baseline and I get a concussion and I'm completely rocked later, if I intentionally fail now, at least my scores after the head injury will be similar to when I was faking it, right? It will not let you continue. So if it has a sense that you're just randomly clicking stuff and you're intentionally getting things wrong, it'll shut down. So when we're testing athletes, especially with impact, it can be really expensive. So with impact, there are some different packages that are available. If your license allows you to test 100 athletes, or if it's unlimited test and retest, but only for the specific names that you enter, or if it's unlimited numbers of athletes, right? If a school is struggling financially and they're not wanting to purchase the impact testing for all of their athletes, they might only test those that are more high risk. So women's soccer, football, cheerleading. Sometimes cheerleading may not even be considered a sport at your school. So even their ability to reach out to the athletic training staff and the team physician might be really limited. So personally, I think if you can't afford quality sports medical care, then you can't afford to have athletics at your school. So if there is a risk of head injury, then all of our athletes need screened for it. Now, it doesn't necessarily have to be impact tests. There are several different ways to evaluate someone's risk of injury. Impact's just, a one way for that, but even on the test itself, it'll say this is not used, or this should not be used to diagnose, treat, or release an athlete from a concussion or a head injury. It's just, again, some supplemental information that sometimes, especially neurologists, might want to look at to be able to have a better idea, maybe structurally, where in the brain some of these changes have occurred when we're thinking about maybe some long-term deficits and things like that. So if we get a baseline of where they perform at the beginning of the season, then after they get injured, we can also retest them with that post-injury testing model. So this does not have to be like immediately after. If someone has a pretty severe concussion and they're, mumbling their words and they're unsteady on their feet, obviously that would be a terrible time to do balance testing or object recall testing or different things like that. I'm not expecting them to succeed. If anything, I'm wasting my time and theirs for something that's not going to give me any meaningful data, right? So if there's a very obvious chance that they are not ready to be released yet, we don't really have that much of a necessity to do immediate post-injury testing on things like impact or balance or things like that. If we know they're concussed, we don't have to go through all the different stages of that impact testing or things like that. We also have BEST testing, which can, again, be a standalone test. We could just do that to assess balance. It's a balance error scoring system. So again, you get a point for each error that you make. Sometimes it's just someone has crap balance. It could be that they have, let's say, an ankle injury. So if we're testing on the right ankle and they have just sprained it, you might want to get some type of baseline measure on the left side, and then once they become cleared from their ankle injury, retest on the right side, because that's the one that would be tested later. So it'll make your data a little bit more meaningful. But before they can be cleared from a concussion or a head injury, again, we here at ESU will do their impact testing. We'll go through that SCAT packet several times throughout, just so we can monitor some progress and changes. So when we're thinking about some specific recognition of head injuries, skull fracture, not super common, but again, if you're taking any direct trauma to the head, we have to be aware that your skull is in a regular shaped bone, right? It's one of the only ones that can have big sinuses within it. So it's relatively hollow, even though there are 8 bones that'll fuse together to form the skull. So if someone does have a skull fracture, right, usually that's when they're feeling around in your head. Do you feel any divots or lumps or anything abnormal? Is there any swelling? Are there any soft spots? Things like that. Usually if they have a skull fracture, again, severe headache, nausea, you'll feel, again, some type of defect there, either a soft spot or something moving under your hands, especially when you move over it, that'll increase in pain. There are some other signs that there could be a skull fracture, especially at specific points of that, if there are bruising in different locations. So there's something called battle sign, where it occurs right behind your ear. So you have this bony lump right above your jaw called the mastoid process, mastoid process right behind your ear. So if there is any bruising on that, it does not have to be, again, a direct contact on that part of the head, but if there is called a basilar skull fracture, you'll have bruising pattern right around that kind of process behind the ear. There's also what's called raccoon eyes. Now, it'll look like a black eye, but there's no trauma to the eye itself. It's just when you have bruising around both eyes, called raccoon eyes. Could be from a skull fracture, could be from a nasal fracture. So again, as the nasal bone attaches to the skull, that's gonna be one of those skull bones. So all of this is cartilage, but you have a nasal bone that ends about a third of the way down your nose. Again, if you could get a broken nose, you'll have 2 black eyes. Not because you had literally 2 traumas to the face, but just where that bleeding will pull. So it's that ecchymosis. The difference between that ecchymosis and that contusion is, again, a contusion is soft tissue trauma. So you got hit there, it's bruised there. Ecchymosis is the pooling of blood just from gravity pushing it down. So, when you sprain your ankle and you have bruising basically all around your heel, that's not because you made direct contact with that part of your heel on the ground and it's caused a bruise. It's because it had bled higher up in the ankle, and then all that blood has started to settle, and then that's where we'll see that ecchymosis pattern. So it's essentially still blood that's there, but again, how it got there is what's a little bit different. When we're thinking skull fractures, there's also another sign that'll come up, and it's called a halo sign. So when we see what's called CSF or cerebrospinal fluid leaking out of the head, that's going to tell us, hey, this is a serious, serious issue. So your brain, let me see if I can do this. If your brain is this nice cloud, right? All wiggly, full of knowledge, different things like that. See if you can see that. There we go. So if this is your brain inside your skull, right, there's not a lot of extra space that's in there. But all around here, between the brain and the skull itself, there are what's called meninges or different coverings. I still can't really see that very well. 3 different coverings of the brain between that and the skull. These meninges will do several different things. One is supplying blood and oxygen to it. Others is just kind of supporting its structure. So when you shake the head, the brain's not just moving all around all willy-nilly. So brain, skull, we have 3 different meninges, which you've probably heard of before in reference to when they get inflamed, right? So think inflammatory condition, itis. This would be a meningitis type condition. So bacterial viral meningitis affecting the meninges of the brain. So there are 3 different coverings when we're talking about the meninges, 3 specific meninges. We have the dura mater, which is a really thick one, closest to the skull itself. Dura is Latin for tough, D-U-R-A. So dura mater means tough. Then we have what's called the arachnoid mater. So the arachnoid, again, is still a covering. It'll be a little bit closer to the brain here. I'm drawing it as little X's because arachnoid, if you have arachnophobia, afraid of spiders, right? This will be a spider web type design. So it's not going to be completely solid. It'll have smaller little openings in it, and again, allow for some elasticity and changes like that. The next one will be what's called the pia mater, P-I-A. Pia means delicate. And that will be the one kind of closest to the brain. And then all in the spaces around the brain, the meninges, and the skull is what's called CSF, or cerebrospinal fluid, okay? So your brain is floating in this own very specific fluid. That's the only place in the body that it is, right? Again, in your skull, kind of around your brain, and then in part of your spinal cavity, okay? So this should never, ever, ever leave the body. When it does, it's always a bad situation. So when you see halo sign, we know that it's specifically CSF that's leaving the body because the density of it or the heaviness of it will be different than that of any other body fluid like blood. So if someone is bleeding from their nose, their ear, their head, right, and you were to take like a piece of gauze or a tissue or something and collect that blood and then look at it later, what you will see is, let me draw it for you. There might be, let's say all of this circle here is blood that's come out. What you will see is a larger around it, essentially halo. So this will be again, you're collecting any of the blood there. And what'll happen is the blood will move to the center, and this yellowish ring, like a halo, like that of an angel halo, will form around it because it is a different density and viscosity or thickness than that of the blood. This halo could also make you think like, well, the angels are coming, because it's again, very, very serious issue. We can't scoop it all up and put it back in the brain. Your body will eventually make more, but it should never leave the body. So if someone is bleeding and you collect that and then you look at it, you will see, again, this halo sign. There are several different pictures I could show you where in like an ER type setting, someone might have a skull fracture, and then on the bed you'll see blood, and again it kind of separates out as this halo sign. So if someone does have a skull fracture and we see a positive halo sign, so again that CSF ring around that drop of blood and fluid, we're definitely thinking skull fracture. So Anytime that happens, again, we're following all of our fracture protocol above and below and in the position found. Well, if it's your skull, you can't really do a whole lot above and below, but we're thinking because there could be some spinal cord involvement, we're still doing a cervical collar, making sure that they can maintain their airway, calling 911 immediately. If your medical staff is already there, that's going to be a spine board situation. EMS will take them to the hospital. They'll be further referred to neurology, and it'll be a surgical situation with a long recovery process. So when we're thinking about trauma, then inside the skull to the brain, our cerebral concussion is sometimes called an MTBI, mild traumatic brain injury. Now, this is a little bit of a misnomer because anytime you're injuring your brain, it's pretty serious. But when we're comparing this to a TBI, traumatic brain injury, this is thinking like someone has to relearn how to walk and talk and feed themselves and function traumatic brain injury, where they're going to have usually lifelong issues from this. But a MTBI, your concussion, these are things that you can heal from. Again, as far as severity, though, you can't really diagnose some of the severity of it until after the fact. So previous texts have talked about like a grade 1, grade 2, grade 3 concussion. Those words are not really things that are used too much anymore because a lot of it was based on how long it took them to recover. Well, you don't know that until they've recovered. And then looking back, oh, that was a grade 2. So not really that practical now. We'll grade a lot of the severity by the severity of their symptoms. So how do you get a concussion? We should already know this. It does not have to be a direct head trauma. So I don't have to be tapping on the head or head down tackle. It can be anywhere in kind of the upper torso. So if I get hit from the back and I have like a whiplash type mechanism, the brain moving inside the skull is what's causing that concussion. So essentially it's a little bit of a bruise where the brain smashes into the side of the skull and causes trauma, usually on that side, but it could also happen on the other side, which is called a coup injury, C-O-U-P, if the trauma is on that side, or a contra coup if it happens on the opposite side. They might, not always, they might have an altered level of consciousness. So they might be not awake or not alert to a verbal stimulus. If you yell at them, they're just kind of staring around, just no idea that someone's trying to get their attention, things like that. We also have to consider post-traumatic amnesia, so the inability to remember things after the fact. There's also some information about a retrograde amnesia versus anterograde amnesia. If you think about retro, past, and then antero, front, future, right? We're thinking before versus after the hit, where's that amnesia happening? So if my thumbs are the hit itself, where's your inability to remember? Before the injury or after the injury? Do you remember what you had for breakfast? Do you remember walking off the field? When we're asking these questions, it is imperative that we also know the answers, right? If you tell me you had Lucky Charms for breakfast, I wasn't there. I don't know if you're telling me the truth or if you're just making stuff up, right? So if I say, do you know what you had for breakfast? And you say, yeah, I won't know if that's correct or not, right? So make sure that you are aware of the questions that you're asking so you can verify some of the answers. Okay, other signs and symptoms, again, can vary person to person. Just having one symptom by some definitions could be a concussion. But again, you have to think about where these things are coming from. If you wake up with a headache, that does not mean that you can or that you will have a concussion, just that you have those symptoms, right? So kind of take it with a grain of salt because again, how these injuries present themselves can be all over the place. Balance problems, sensitivity to light and sound, feeling slowed down, feeling in a fog, sorry. Overall, just don't feel right. It might be difficult to describe what's actually going on, but you just don't feel right. Fatigue, low energy, irritability. So again, some of those personality changes, sadness. Sometimes people will just get really emotional and just start bawling their eyes out, right? It's not because something super sad has just happened. It's just the ability of them to regulate their emotions. That portion of the brain has been the part that's injured. And that's going to be some signs and symptoms of a concussion. But again, you don't have to have, 5 to have a concussion. If you have 30 of them, definitely probably pretty severe, but there's no specific number that you have to diagnostically have a concussion. Again, we can't x-ray it, MRI it, CT scan it, blood test it, scat test it and know definitively, this is where the concussion starts and ends and things like that. We can't see those things. It's all based on how the symptoms present. So if they're lying about them, that's going to be a huge, huge issue for us because we don't know the extent of the damage by right away. So by having a lot of these other testing procedures, we can rule out other injuries. So we could, x-ray their neck and head to rule out a skull fracture. They might do a CT, MRI looking for like nerve root or disc issues, right? But as far as brain function, yeah, you can do what's called this isn't important. You can do a what's called a functional MRI where you have like the blue and the red and the yellow zones of the brain, different areas lighting up when you're doing different tasks or when you're thinking about different things. Again, that's not something that we would really do. That would be something for like a neurologist to maybe do. But again, there's no definitive test. There have been some studies and news releases about different blood tests that might be used for diagnosing a concussion, but a lot of that stuff that's immediately released, some of these proteins, they're going to only be in the bloodstream for sometimes up to an hour after the concussion itself. So if you're relying on that test to diagnose it, you might not even see a medical provider within the first hour, right? A lot of these symptoms can also increase and decrease in severity. You might not have the worst headache now, but when you wake up tomorrow morning, oh my gosh, is it going to be terrible? Just the lights causing you issues and just nauseous and just feeling like garbage, right? So typically if there has been a serious hit and you don't even have a lot of signs and symptoms, but the team physician or the athletic trainer still has some reservations about it, they might pull you from activity just because they're expecting these symptoms to worsen over time. Again, they may lose consciousness, but they don't have to. In some cases, when someone has lost consciousness, they're not going to know how long they were even out for. If it has been an extended period of time, again, it could be seconds, it could be minutes, right? The longer that you are unconscious, though, we're definitely knowing that it will be a little bit more serious. So we've already talked about some of the care with physical and cognitive rest. If they have lost consciousness, that's an immediate pulling from activity. Anytime that we are dealing with a unconscious athlete, we need to follow C-spine protocol. So that's going to be cervical collar, spine board until anything more serious has been ruled out. So again, because we don't have x-ray vision, we need to just make sure that we're following the proper protocols to make sure that everybody stays safe. And then there has to be a gradual return to play protocol in place. Now, as far as how strict that is, of course, we will use the SCAT, many colleges, universities, FIFA, US Olympic Committee, they'll use that one also. Again, it's endorsed by all those organizations, NHL even at the bottom. But as far as if you have to restart the whole protocol all over versus if you can kind of start and stop in that same phase day after day, you have a little bit of leniency. You also have your team physician to lean on. So it's ultimately their responsibility to clear that athlete. So if you feel that they're ready as a coach, as an athletic trainer, as a parent, as a teammate, as the individual, and team doc says no, well, then they're not cleared to return, right? At that point, that would be something where they might then refer them to a neurologist or someone like that that's a little bit more highly trained specifically on those type of head injuries. One of the reasons that you might stay out a little bit longer is for something called post-concussion syndrome. Now, this is different from another condition that we'll talk about here in a minute called second impact syndrome. But post-concussion syndrome, we're thinking that this happens after the physical trauma of the brain has healed. So essentially it's, again, like a bruise. So after it has healed, but you still have symptoms, that's when you're going to have post-concussion syndrome. So everything else should be fine, but you still have symptoms. You still have memory loss. You still have fatigue. You still have visual disturbances. You're seeing double, or things are fuzzy, or you just have constant headaches, even though the physical trauma has healed. This can be really difficult to treat because we don't know what's causing it because structurally there's no reason that it should happen. This is also one of the reasons that a lot of protocols have changed from just having a long rest period. So it used to be recommended, again, physical and cognitive rest until you are completely symptom free. But if that means you're laying on the couch for a week or two, obviously when you start light activity, you will have a headache, you will have fatigue, you might get a little nauseous because you have done literally nothing for a couple weeks. So now the recommendation is yes, rest, recovery, sleep, whatever. But after, the first couple days, start moving around, right? We're not going to make ourselves further disabled by not taking care of ourselves, right? So, try to continue with your daily activities, not driving or stuff like that, but, get up and walk the dog, go ahead and cook some dinner, go ahead and go check the mail, right? Being able to move around should help with some of that active recovery and allowing the body to heal itself a little bit better versus just complete rest until you are completely free of signs and symptoms. Now, second impact syndrome, this is a little bit different because of when that second hit occurs. So in the time that you still have some of the physical trauma and usually signs and symptoms of a first concussion, you get a second concussive blow, right? So again, it does not have to be direct head trauma. It could be to the neck, to the back, to the chest. We cannot control how the brain is moving within the skull. So if you are still having the original signs, symptoms, physical trauma of the first injury, and then you get a second blow, what happens is a catastrophe that we cannot stop. So what happens is the brain will begin to swell rapidly. Now, again, there's not a lot of space in this skull anyway. So when it starts to swell and swell and swell, it's going to run out of places to go relatively quickly. So it's sort of like compartment syndrome, and there's nowhere for it to go. It's basically starving itself from the inside out. This is also what's going to make it, unfortunately, usually a fatal condition. Once this starts and we have some sodium potassium leakage within the body, we cannot stop that process. So even if you are, a couple minutes away from the hospital, they might be able to catch it. But in some cases, again, once that brain herniates or kind of pushes its way out of its space, you can't just shove it back together, right? Your brain is going to be the hub for communicating signals to the rest of your body. So it can't regulate itself. It will have a change in what's called ICP, or intracranial pressure. So again, that pressure is going to continue to increase as the brain is swelling. To treat it, again, this is not something that we are doing in the field. This may not even be like definitely not an ER type thing. They're going to get, again, surgeons involved in this process. What they will do to release pressure, similar to a fasciotomy, they'll do what's called a craniotomy. They will drill what's called burr holes, or just small little holes in different parts of the skull to allow for the brain to swell a little bit. Now, anytime you're dealing with brain things, again, there's a lot to consider. Just the nerves that are surrounding it, a lot of the blood flow. If you do have a decrease in blood flow to portions of the brain, like a stroke, that can be separate from a head injury, it can just happen sometimes. That damage can be irreversible. There's a very finite amount of time where you can have serious intervention and the likelihood of it working will increase. But unfortunately, it's a really short window. So if someone doesn't have this immediate referral for this second impact syndrome, the chances of it being a fatal condition are astronomical, unfortunately. Again, we cannot stop this once it starts. As the brain starts to lose its ability to self-regulate and allow your heart to pump and allow the breathing to continue and blood flow and things like that, you will lose consciousness and then unfortunately usually pass away. The good thing about second impact syndrome is that it is completely preventable. And how is it going to be prevented? Well, not getting that second impact. Well, you can't necessarily help what happens to you, but part of it is still being honest about the first signs and symptoms of the concussion in the first place, right? So if we know that you have concussive symptoms, we can, again, start this protocol to limit your risk of getting hit again and prevent that second impact from ever happening. There are some diagnostic pearls to second impact syndrome. It can only occur in athletes that are younger than 25 years old, where their brain is still developing. Some people theorize that if second impact syndrome was as real or as serious as some clinicians believe, then why are there any boxers that are 30 years old, right? Different schools of thought, but because we are so cautious, because we know that these things exist, We have a duty to protect our athletes to the best of our ability. Now, likewise, they also have the responsibility to be honest with us. So if they are showing signs and symptoms, report it, right? If your teammate is showing signs and symptoms and they're not acting right and they're, talking gibberish and just not acting like their typical selves, you could save their life by reporting this. So yeah, they might miss a game, but when the alternative is missing the rest of their life, the rest of their senior year, the chances of, settling down and graduating and getting there and all those other things to look forward to in life, it's definitely worth, sitting out a couple days. Okay, last couple conditions, when we're again talking about some of the structural things, remember that outermost meninge is called the dura mater, okay? The next two conditions are relative specific to some of these meninges. So we have what's called an epidural hematoma and what's later called a subdural hematoma. So we're looking specifically at that dural layer, and then is it above it or is it below it where this hematoma, a collection of blood within a space, so like a blood clot, will start to form. So an epidural hematoma above that dural layer, right, is when bleeding will occur in that meninge and then blood will continue to spill out. It's essentially the same thing with a subdural hematoma, but the location of it changes above or below that dural layer. And because of its physical position of where it's bleeding, the symptoms will also be a little bit different. Now, this can occur with a concussion. It's kind of separate of the actual brain's trauma. It's just another physical condition. But how some of this bleeding will affect them will be very different. So with an epidural hematoma, the signs and symptoms will happen relatively quickly. So they'll have, I think that's my next slide. Yep. They will have head pain, dizziness. They might have neck pain. This is going to happen again relatively quickly. Again, it might turn into a headache and then now it's going to get more severe, or they might have a little bit of confusion and dizziness and it'll continue to lead to maybe a loss of consciousness. Again, when we're thinking about the location of it, there are different types of procedures. Again, the burr hole procedure, craniotomy to relieve the bleeding. But again, you don't want to try to give them any medication for it. You may have heard, if you're having a heart attack, take an aspirin and stroke risk and stuff like that. Again, if we're consuming things and we're in and out of consciousness, there's not only a really high risk of choking on that, but again, if we're intentionally trying to change the thickness or the location of our blood within our body, it can cause a lot of other issues. So comparing a epidural hematoma to a subdural hematoma. So the bleeding is now under that dural sheath. This is again a venous bleeding. So it will be a little bit slower compared to that of an epidural. So the symptoms being relatively quickly and then gradually getting worse versus it will be a slower bleed. This can take hours or days sometimes to be diagnosed. So when we're thinking about the more serious nature of it, you're definitely going to see something that warrants referral with an epidural hematoma. It's that immediate trauma where, it's bad and then it gets immediately worse. With a subdural hematoma, what can make it more fatal sometimes is because it's not that bad right away and it's just a very slow progression. So, again, they should receive immediate medical attention, but this is something where, let's say they get hit and they don't feel right, so they're just going to take it easy the rest of the day. The next day, they're not feeling really great. The next day, maybe even worse. The next day, again, it'll be slower to progress, but again, it is a continuous bleed. So if they don't get it checked out, it can put pressure on the brain as that space is continuing to fill with blood, and it can cause that brain herniation. That's when they're looking to see dilation of one pupil. So it should be, a normal size and it's just getting bigger and bigger and bigger. If you watch like medical dramas, if they say the pupils are blown, again, they are giant big and they are fixed. So if you shine a light in them, they don't constrict to the light, they just stay giant. That can be a sign of a brain stem herniation. So that brain has already kind of pushed out of its space. You hear about this condition a lot, the subdural bleed being fatal. There was an Olympic snowboarder, I cannot remember her name, but again, took a tumble on the slopes, wasn't feeling really great, went to bed, that night, not feeling really great, and then just didn't wake up. So this cannot be ignored. So when you're thinking, well, is it a concussion or is it more of a brain bleed? It's always something that we are aware of, but there will definitely be symptoms with both. So if those symptoms get real bad real fast, it definitely warrants a referral. I don't care if it's the middle of the night, you text your AT or you send your roommate to the hospital, you drive them there, you call EMS. We need to get them medical attention because a lot of this stuff, again, we cannot see physically with our eyes. So because we can't see a bone sticking out or see the active bleeding, we might kind of discount the seriousness of it. Know your people, know what's normal and what's abnormal, and then make sure that they get the